It will be interactive, so feel free to interact, to give your advice and what you think about the images. And there will be 3 or 4 quizzes according to the time left. And the first one is this one. This patient was referred at 24 weeks of gestation because of the length of the corpus callosum, which was considered as small, reduced. And it will be a short question like that. For this patient, what do you think? Do you think it's normal midline? There is shortness of the corpus callosum. There is ascension of the third ventricle, absence of the cavum septum pellicidi. And what about follow-up or no need for follow-up? So, normal midline, what do you think? Oh. Short, okay, short, 2 for sure. The third ventricle, in place or not? So, you can see here, oh, sorry. This is not the third ventricle, the cavum septum pellicidi here. And this is the third ventricle, which is in place, in fact. So, shortness of the corpus callosum, yes, for sure. At 22, it should be 22. So, at 20, almost 25, it's short. And what do you think about the follow-up? You will do a follow-up? I think it's a good idea. This is the follow-up. So, in the same time, I saw patients at 27 and at 29. And at 29, I do both an ultrasound and MR. And this is the coronal view. So, sagittal and coronal view. And what do you think? The corpus callosum is still short. Do you think that there is a agenesis of the corpus callosum? Do you think there is hemorrhagic lesions of the posterior part of the corpus callosum? Do you think it can be tubulonodular lipoma? And what do you think about this pathology? Severe, not severe, benign? So, for you, what is the correct answer? 4. Tubulonodular lipoma, okay. And that's it. Okay. Corpus callosum agenesis, for sure, if there is lipoma, there is, most of the time, corpus callosum agenesis. You know the 2 types of lipoma. There is 2 types of lipoma. There is the tubulonodular lipoma, which is surrounding the corpus callosum, and another lipoma which is surrounding the corpus callosum, which is the I will show you. The curvilinear lipoma. There is 2 types. I will discuss the 2 types. Now, the question is, regarding the curvilinear lipoma. What is a curvilinear lipoma? It's most often associated with a short corpus callosum, minor or moderate corpus callosum agenesis, better identification at the last stage of pregnancy. MR diagnosis is based on the characteristic hypersignal on T1 sequences, characteristic of fatty contents, and T2 weighted sequences imaging are most often normal. This is, in fact, a curvilinear lipoma, this one, and we'll discuss. What do you think? Associated with a short corpus callosum, yes or no? Yes. This is the case where the corpus callosum is short, and you have this, okay. Moderate or minor corpus callosum agenesis? Yes. Identification of the lipoma is better in the late stage of pregnancy. Yes, you show how it was at here, and it become like this. So you see that the identification of the lipoma will be better in the third or the second half of pregnancy. You know also that lipoma, when you do an MR, you find the lipoma on T1 because it's an hypersignal. But you need a lot of fat. In the prenatal period, you will not see hypersignal with T1. But instead, you will find a hyposignal here on T2. So if you if your radiologist do not do ultrasound, and if he is not aware of that, he will never think that it's fat. Because for a radiologist, postnatal radiologist, fat is a hyper signal in T2 and T1. And here, because the amount of fat is reduced, it's not enough to get a hyper signal on T1. And I will not discuss, because it's too complicated, why there is hyposignal in T2, but this characteristic. And I will show the patients after birth. Here, on T1, it's characteristic, but you are in the postnatal period, okay? And you see, on T2, you don't have the hyposignal, though the signal of fat will change. So it's a pitfall for such diagnosis. This is the two type. You have the tubulonodular, which is most of the time anterior, which is associated with many anomalies of the face, and you have the curvilinear lipoma. The agenesis is less severe, and you have most of the time no anomalies of the face. On this type of situation, the cognitive outcome is in most of the time a good outcome. So when you go back to this story, most of the time you find a short corpus callosum when you do your ultrasound in the second trimester. When you are dealing with short corpus callosum, you think about cognitive issues, and sometimes you cancel for termination of pregnancy. If you have your short corpus callosum and you see there is an ecogenic line above the corpus callosum, you have to think that it can be a pericallosal lipoma. In that case, you have to follow the pregnancy, and 2 or 3 weeks later, you will see that the echogenicity is increased. In that case, we can confirm that it's lipoma, and for the baby, it's good, because in that case, the cognitive outcome will be good compared to the uncertain prognosis of a short corpus callosum. Okay? So it's very important. I will show you, it was a resident in hospital, she was pregnant, and there was a first ultrasound performed by one of our physicians, and he told me, it's funny, I think the corpus callosum is short. We are 23, and it's 19. For sure, it's short. But I have a look at his ultrasound, and I say, do you think the pericallosal sulcus is too echogenic here? Too echogenic. And this patient was in holidays, and I have the opportunity to see her some weeks after, and this is at 27. You see, here it was tiny, but here it's obvious if you know that you are looking for fat here. Okay? So this is a very important issue when you are dealing with short corpus callosum. Yes?
What's your tip to differentiate short corpus callosum from a partial agenesis?
It's difficult. The question is, can we differentiate partial agenesis or short corpus callosum? Because it can be interesting to do some tractography in such cases, because you see the splenium, the genu, and you see the rostrum. So you have the feeling that the corpus callosum is compressed by the pericallosal lipoma, which is present before, because you know that lipoma is just a lack of resorption of the primitive meninges between 4 and 5 weeks of gestation. And because of this lack of resorption, these primitive meninges will transform in fat. So the fattest tissue will be present before the development of the corpus callosum. And because of that, maybe the axons are compressed. I cannot say that. But because we know that this kind of agenesis are mild, with a good outcome, it can be more agenesis than a real partial agenesis of the corpus callosum. Yes?
I'm just learning there. In the previous one, it seemed like the echogenicity was within the corpus callosum, whereas here it's just above.
Very.
Does that make a difference?
This is above. In fact, sometimes it's just a little bit, not in the midline, but a little bit off midline. But it's always above the corpus callosum. And if we go back to this one, you see the corpus callosum is here, and the lipoma is above. Okay, and in the pericallosal lipoma, most of the time the thickest part is more posterior than in case of tubulonodular. Yes, this is our MR. Nothing on MR. Hyposignal here, and this is after birth. And you see, it's important for you, but important also for radiologists, because when they perform the MR, if they are not aware of that, they will miss the diagnosis. And so this is online and will be, in fact, the paper will be soon in the White Journal. So it's limitation and pitfall in the prenatal diagnosis of pericallosal curvinal lipoma based on a specific imaging pattern. Okay? Quiz 2. It's easier. This patient was referred for borderline ventriculomegaly. And I have a question for you regarding cerebral maturation and regarding what we did this morning. And we said about Cillian Fisher. For you, this patient is approximately at 24, 26, 28, 32, or other choice. So you look here. You see, you know that at 24, it should be square. And after, the temporal lobe will recover the insula. So is it square? No, it's open. So there is maybe other choice, which can be 20, 22, but. So you know that. I saw Rabi show this morning. But we are, in fact, in this patient at 26. So you put your probe at 26, refer for mild ventriculomegaly, and you have this. So if you do an analysis of this, what do you see? Is it the ribbon, cortical ribbon, or is it the surface of the brain? With ultrasound, the echogic line, is it the cortex, or is it the surface of the brain? For sure, it's the interface between the subarachnoid space and the parenchyma. So it's the surface of the brain. You don't see the cortex. With ultrasound, you don't see the cortex. Somebody tell you that it's a sick cortex, and no, the cortex is not seen. You see just an interface because it's parenchyma and peripheral spaces. So what you can say, there is a lack or a pathological maturation of the Seldon fissure, and there is a smooth surface, okay? So according to that, if it's a smooth surface, what do you think are the diagnoses which are the most likely? Diffuse polymicrogyria, cobblestone lissencephaly, severe simplified gyral pattern, subependymal heterotopia, lissencephaly type 1. So, diffuse polymicrogyria. Nobody. Cobblestone lissencephaly. 1, 2. You know, cobblestone lissencephaly, there is, in fact, a problem, an issue with migration, but there is over-migration. That means that the neurons will migrate within the pre-cell spaces. So the echogenicity here will not be anechoic, it will be hyperechoic, because it will be full of neurons which over-migrate. In that case, the echogenicity is normal. So there is no over-migration. Severe simplified gyral pattern. You know what is? It's microcephaly, because there is a lack of proliferation in germinal matrix. So there is less cells. So because there are less cells, you have a small microcephaly. And because of that, the gyral pattern is very simplified. And in some case, it's very, very simplified. So you have something very smooth, which looks like a lissencephaly, but it's not a lissencephaly. Because lissencephaly here can have a smooth cortex. And when you are sonographers, or you are doing only ultrasound, when you see a smooth cortex, you can say, yes, it's lissencephaly, because the different, most of the lissencephaly, type 1, have a smooth cortex. But smooth cortex can be encountered in lissencephaly type 1, severe simplified gyral pattern, and also the undulated pattern can be so small that you have the feeling that it's smooth. That this one, and this one are correct. I can show you, if you were at the pre-course, I showed the maturation of the brain. At the end, I showed lack of maturation, and it was a diffuse polymicrogyria. It was exactly the same image. So, because what you are looking at here is the surface and not the ribbon. If you want to see the ribbon, it will be interesting to do an MR to differentiate between this, and this. Because when it's diffuse, it will be, you will see more undulated, and you will see the ribbon. When it's lissencephaly, you will see abnormal migration, and severe simplified gyral pattern, you will see a normal, in fact, a normal ribbon. So in that case, we did an MR. So on the MR, what you are at 7 or 28 weeks of gestation. What do you see, and what's your diagnosis with this? For sure, you can differentiate the three entities with the MR, because here the ribbon is well visible. You see you don't see the surface. You see really the hypointensity of is in fact the cortex. But this is a part of the cortex. But what all this? You know, there is okay. Which features are present in this case? Undulated cortical ribbon. There is no undulation at all. Diffuse neuronal migration anomaly. What do you think? Is there diffuse neuronal migration anomalies? Yes, of course. Why? Because all this hypointensity, this laminated pattern, it's very abnormal at 28 weeks. That means all neurons coming from the germinal matrix going to the cortical surface have stopped in the middle of the pathway. And all these are neurons which do not migrate. And this is the definition of a lissencephaly type 1. It's a diffuse neuronal migration pathology. Okay? So overmigration, no overmigration. This overmigration, it's lysencephaly type 2. And megalencephaly. Megalencephaly, can you tell me what is the process, the abnormal process in megalencephaly? To all this process, all these pathologies of the will be divided in 3 large entities. The first one is trouble in the proliferation, trouble in the migration, and trouble in corticogenesis, on the cortical organization. When you are dealing with polymicrogyria, it's the cortex, formation of the cortex. When you are dealing with lysencephaly or heterotopia, it's the migration itself. Some cluster of neurons do not migrate and stay on subaboundable surface, and this kind of things that you can feel found with filamin mutation. This is a diffuse neural migration, and for megalencephaly, what it is? In fact, it's a pathology of the proliferation. The proliferation, the number of neurons in the germinal matrix are okay, but the phenotype of the cells itself is pathologic. That means you have very large cells, and all these cells which give you the cortex and the white matter. But because of its very giant cells, they cannot organize and migrate correctly. And because it's a mutation on one side of the hemisphere, or on one part of one hemisphere, all the cells, neurons, and white matter, glial cells, will be abnormal. Because they are large, there is some number of cells on both sides, but because they are large, it increases the volume of the brain on one part. So if you are dealing with proliferation disorders, you have a decreased number of cells when you have primitive microcephaly. When you are dealing with the phenotype of the cells, you are dealing with megalencephaly. When you are dealing with migration, it can be heterotopia. Diffuse migration is lysencephaly type 1. Overmigration is lysencephaly type 2. Corticogenesis, polymicrogyria. It's clear? Yes. Okay. I think it could be a good course just to correlate the different steps of the formation of the cortex with all these conditions. Yes?
How do you interpret in the top left image it looks as if the cavum septum pellucidum is divided in 2 portions?
Yes, I think I'm a little bit low because I think it's the fornix colon.
The fornix.
Yes, here, I think so. You are a little bit up here. Okay, so perfect. Okay, lysencephaly. This is another example of lysencephaly type 1. So I did this editorial in July, last July. Some, in fact, tools to elucidate decreased cephalic biometry. And one tool is do not assume that a smooth cerebral surface using ultrasound is similar to lysencephaly. It can be also diffuse polymicrogyria, microcephaly with a simplified gyral pattern. So in that case, it's very interesting to do an MR to have a real good interpretation of the thickness or of the anomalies of the ribbon, which may be undulated in the case of polymicrogyria. Okay? Now, we have, it's okay? 5 minutes? Okay. If you want to stay more, I can stay more. I have a... Okay. So case 4, patients with fear at 25 weeks of gestation due to abnormal CNS organization. So sorry for this, because there is... but I did that just for you to have a good view of what I want to show you on the proximal part, on the distal part, sorry, of the brain. And to come back to the question, what do you think? Based on supratemporal structures, the sonographic imaging features are subependymal heterotopia, Cilium fissure operculation in accordance with gestational age, we are 25, pericerebral hemorrhage, overmigration, distortion of the interhemispheric fissure. Flavia. Yes. Okay. You say 4. Okay. Who say 4? 1, 2. Yes. 5 or 6 people say 4. Who say pericerebral hemorrhage? 5. Okay. Yes. I understand why you said 5, and yesterday I told myself I shouldn't put this one here because this is in fact straight, but here we can discuss. But we'll say that it's straight. So don't forget this one. There is no distortion at all. So okay, what do you say, Antonio, that it was 4? What do you see?
Thick layer just around the ventricles over there, and you have described in the sagittal view the kinking.
We go. It's the next one. You are a good reader of the medical literature. Yes, you are right. You see, the surface is here, and you can you lost the surface here because it was full of neurons here. So there was over-migration of neurons. And we'll speak a little bit later about this over-migration. So over-migration was a good answer. Based on sonographic analysis, what do you think? We are 25, normal TCD, Vermean agenesis, embryonic aspect of the brainstem, infratemporal over-migration, and callosal agenesis. Normal TCD, we are 25, it's 28. It's okay. Okay. After 25, it's after 24. There is, in fact, asymptotic curve of the growth of the TCD, so it's correct. Verm digenesis. Where is the vermis here? Very difficult to say. Where is the vermis? Okay. What do you think about the brainstem? Yes, if you follow the brainstem, it's going here, here, and here. So there is a kinked brainstem. Okay. Is there any over-migration? In fact, look at the brainstem. It's the hypoechogenic part. But what's this? The hyperechogenicity here. And the hyperechogenicity which here surrounding the cerebellum. It's exactly the same thing. It's over-migration of neurons which go in the peripheral spaces. As you may know, when you are at 8 weeks of pregnancy, the brainstem is kinked, and it will be straight after that. But because of the over-migration, is stuck in the primitive aspect, and it stays in this primitive aspect because of the over-migration. Okay? So this is, in fact, all is okay. So this is suggestive of diffuse over-migration. This is it diffuse over-migration? Yes, I just show you that it's supra and infratentorial. Cobblestone encephaly. Yes, it's the other name. Dystroglicanopathy. Yes, perhaps. We will speak about that. Most likely mutation of POMT1 and POMT2. Yes, it can be. Yeah, because the genes which are most often involved in such over-migration is POMT1 and POMT2. Walker-Warburg syndrome. Yes, it's the name of all this. Okay. So what's dystroglicanopathy? There is some molecules of dystroglycan which are here just to say to the neurons, stop to migrate. it's enough, and now you stop to migrate. There is peroxide bases here, germinal matrix here, you stop. But this glycan should be glycosylate. You understand glycosylate? I'm not sure it's a good. Because of this mutation, there is a defect in the glycosylation of the glycan, and it's inactive, the glycan. So the glycan stays like that, and the neurons go like that. It's a dysglycanopathy related to POMT1. It gives you diffuse overmigration. For the pathologist, it's callosal mesencephaly. And with all this, it's Walker-Warburg. It's all the same thing. Okay? It's very clear. Okay. So what's interesting, you see that overmigration is not well visible in MR. It's better with ultrasound, where you see it was echogenic, but it's with MR, it's less visible than with ultrasound. And you see that the surface go to the vault because of this overmigration. Okay, so you see on the pathological specimen, all these are this. The cortex stops there. And if you do histology, the cortex is here. And all these are neurons in the pericerebral spaces. So it was this paper that we published last year. I have another case if there is just to stay, and it will be enough. Okay? Yes? Okay. Okay. So this one is simple. We have discussed about such case in previous session. The patients will refer, in fact, for anomalies on the brain, suspected, and also on extracerebral anomalies. There is something wrong with the BMS for the guys who did the scan. And you are the expert. And the question is, what do you think? You are 21, normal cerebellar biometry, TCD, normal fourth ventricle, cerebellar peduncles anomaly, Birman agenesis, and black post-cyst. What do you think about that? The fourth ventricle is normal for you? Oh, no, not normal. Why it's? Is longer, yes. Why is longer? Yes, because the peduncle are elongated and thickened. Okay? So this is the motor sign. And there is Birman agenesis. Sometimes there is a cyst here, a cystic structure. Don't say this is a black spot cyst. It looks like, but in black spot cyst, the vermis is completely normal and its variant normal. Here, if you say it's just a black spot cyst, you will have some surprise at birth. So don't. Okay. So this patient was referred for other anomalies. In keeping with the cerebral features, you are looking for the following anomalies: cardiopathy, aneuploidy, anomalies of the extremities, echoic kinase. Important to look for the fetal sex. What do you think? 3 and 4, yes, 3 and 4. Are you a radiologist, genetician? Ah, thank you. Okay, perfect. Okay, why? Because you are in this kind of situation, and as you say perfectly about this, if you put this on this way, it looks like a molar tooth. Okay, this is in fact the same thing. Sometimes you have a larger cyst here, but you keep the fact that the fourth ventricle is elongated in AP diameter. In that case, you have this kind of cyst, but you can say, oh, it's a black spot cyst. Yes, but with the black spot cyst, we never have this kind of images. So in that case, the baby has also very large and ecogenic kinase. This is, in fact, in the white list of syndromic entities with ecogenic kinase, you have fetalopathies. And this is fetalopathy, Joubert and Joubert-like syndrome. Okay? What is the other thing that you can find? This one was referred for hexadactyly. When you have a patient referred for hexadactyly, even it's a black patient, because hexadactyly is very often common in the black population, you have to have a look at the fourth ventricle, because it can be, for sure, a Joubert if it's de novo mutation. This is hexadactyly, and it was the case with the molar tooth. So this is some cases of Joubert syndrome. So you have to know the semiology of the molar tooth, but you have to know also that you can enter in Joubert syndrome by the extremities and by the kinase. Okay? We published in 2014 this article saying that it's easier to do the diagnosis just by looking at the fourth ventricle. The fourth ventricle, as you know, the EP diameter is smaller than transverse diameter, and because of the elongation, there will be a deformation which is characteristic of the molar tooth, and that's it. Okay?